Hi, everyone, and welcome to the Center for Optimizing Rural Health's monthly webinar. I am Cassidy Ovula, and I will be with you today as we move through preventing violence in healthcare. What do we know now? And at this time, I would like to remind you that you are muted. However, we do welcome questions. You can type those into the chat box now, or you can save those for the end of the presentation. We will be sharing the slides with you in an email following the presentation, along with a short 60-second survey. But now I would like to take a moment before we begin to introduce our speaker today. Our speaker is Ms. Linda Enos. Ms. Enos is a certified occupational health nurse and certified professional ergonomist with over 30 years of work and consulting experience in industrial and healthcare ergonomics and safety with over 200 companies nationwide. She holds an undergraduate degree in nursing and a graduate degree in human factors and ergonomics from the University of Idaho. And prior to working in occupational ergonomics, Ms. Enos worked as a nurse midwife, staff nurse in NICU, medical surgical units, home health care, and nursing homes in the UK, and as a staff nurse in an 80-bed neurological rehabilitation hospital, and as an operations manager for 5 outpatient clinics in the US. Ms. Enos has authored numerous technical presentations made at national and international conferences and published several articles and a book chapter advocating for safe patient handling and ergonomics programs. She has been a contributing author for several ergonomics, safe patient handling and mobility and workplace violence guidelines and standards, including the American Nurses Association Interprofessional Safe Patient Handling and Mobility Standards, 2013 and 2021, and the Federal OSHA Guidelines for Nursing Homes. In 2017, Ms. Enos recently completed a 2-year project for the Oregon Association for Hospitals and Healthcare and Health Systems that included providing assistance to 5 hospitals in Oregon to review their existing workplace violence prevention programs and develop comprehensive program plans to address workplace violence perpetrated by patients and families toward healthcare staff. Assistance included completion of a comprehensive gap assessment, analysis of worker injury data, and conducting staff surveys. Using lessons learned from this project and an extensive review of violence prevention literature, Ms. Enos developed a comprehensive toolkit for prevention violence in healthcare. The Oregon Workplace Safety Initiative Workplace Violence in Healthcare, a toolkit for prevention and management, was published in December 2017 and extensively updated in March 2020, and she will be sharing that toolkit with us today. Ms. Enos has since worked with several state hospital associations to conduct workplace violence prevention workshops that are based on the Oregon Workplace Violence Prevention Toolkit that are offered to hospitals and other healthcare entities throughout a state, either in person or via webinar. In 2019, Ms. Enos assisted the Oregon State Stabilization and Crisis Unit to further develop their workplace prevention violence and prevention program for 23 group homes for adults and children. And in 2014, Ms. Enos received the Ergonomics Professional of the Year Award and the 2017 Advocacy Award for Safe Patient Handling. So Ms. Enos, thank you for being with us today. We're very excited to learn from you, and I will turn it over to you now.
Thank you, Cassidy, and I think I should have just sent you a paragraph. Bless you for reading all of that.
You have earned it.
I've been in occupational health, safety, and ergonomics for a long time, so the longer you're in it, your CV and bio gets long. So thank you for that. The exciting news I'll add is that we're probably going to use our toolkit in Oregon to help the state hospital, and they're using it to look at a comprehensive program for our state hospital for behavioral health patients. I'm kind of excited to see what they do with it. If some of you have been to workshops that I've given in some other states, welcome. I had the privilege of being in Missouri and Louisiana prior to COVID. I worked with Nevada, Washington, Oregon. And if any of you were in Iowa, the Iowa Hospital Association are allowing me to present a 6 week. One is a session a week course on workplace violence programs for your committees within hospitals. So if you're in Iowa and you're interested in attending that, that starts at the end of June. I think it's either free or very low cost. I'm not involved with that end of it, but I just wanted to give a plug for that. In addition to, I have a finger in many pies, as you can see, not just workplace violence prevention, but I also work at the bedside with staff at a local teaching hospital in Portland, Oregon. I've been running their safe patient handling and helping with ergonomics programs for 10 years, and I'm able to go in and consult with patients and problem solve. So it keeps me grounded, especially during COVID, to be actually working with frontline staff. And of course, this topic crosses over into, we're talking about violence today, but it also crosses into a lot of elements of staff safety that we'll cover. So as Cassidy said, and if I can get this to go forward, let's see this. Well, there you go. These are just our objectives today. Big topic, but I'm hoping, even if you're familiar with this, there's something for everyone. And remember, as we go through, if you're a small healthcare facility and it feels overwhelming, although you need all the elements that we're going to talk about today for a successful workplace violence program, there are many different ways to scale this down. And when we get to resources, we'll talk about the toolkit, because we designed that to help everyone across the country, and it's gone beyond the US, so you don't have to reinvent the wheel. So we're going to follow the toolkit contents today, and I thought we'd start with resources just so that it puts everything into context, and we'll look at the scope of the issue, talk a little bit about safety culture and why programs don't work well if we don't consider our organizational culture, and then what do we know about effective and sustainable workplace violence programs. And Cassidy, I will ask you a favor. If anyone has questions in the chat box, it's often hard for me to follow that. If you wouldn't mind either keeping track of those for the end, or if there's a burning question we can answer as I go through, I'm happy to do that as well.
I would be happy to monitor the chat.
Thank you. So let's talk about some resources. This is our toolkit. If you're not familiar with that, it really is a one-stop shopping for workplace violence prevention programs. We did a huge amount of research over a period of 2 to 3 years, updating in 2020, and I'm actually working on adding more resources now. We want to keep this as an active living document. But we researched worldwide, and what are the best practices for preventing violence in healthcare, and then working with our 5 hospitals. We actually had 10 projects running, 5 in safe patient handling and 5 in violence prevention. We tried things out. We tried out what tools would work for prevention, what kind of program approach, and I'm going to share some of that as we go through today. This project was funded by the Oregon Hospital Association Foundation, but it was in partnership with the Oregon Nurses Association and SEIU 49 and Oregon OSHA in the background. So it's very much a collaborative approach, an interdisciplinary approach to, okay, what do we do to create sustainable and culture-based programs? So take a look at that on the website. What I will say is that make sure you go to the tools section, which is a drop down, and you'll see all of these tools that we reference in the toolkit that you can download and adapt for your facility. And we're fine with everyone using them as long as it's not used for commercial purposes. You're probably all familiar with the Joint Commission Compendium of Violence Prevention Resources by now. Our toolkit has been included on their website since 2017. It's included in the compendium, but there are many other great resources on their website. So make sure that you're familiar with those. And what I've done with the handout while I'm thinking of it, I've sent you the index to our toolkit with the links, they're live links within the PDF to each of the tools and the chapters. I thought that might be helpful for you. Some other resources for you that are related to the topics we're going to cover today. Bullying in healthcare. There's a new document from the American Medical Association that you might find of use. They also have some resources there. We're going to focus on patient violence today, but as the Joint Commission states in their standard, we're talking about all types of violence when we're addressing violence, not just our patient violence. There's another resource on intimate partner violence from Joint Commission. And then we're going to be talking a lot about culture of changing culture in healthcare. So there's a couple of useful documents I've found and resources if you're not familiar with these from the Institute for Healthcare Improvement. I also like to always put this slide up, and unfortunately we need to in light of what we've been through in healthcare in the last 2 years. There is an excellent document that can help you develop a program to deal with the PTSD that our healthcare workers are experiencing now, especially those that have been dealing with COVID patients for so long and so much death at such a young age. And this is what I see with my colleagues where I'm working, a lot of very, well, I'll be honest, employees in their 20s that have seen far too much death and heartache in the last 2 years and are having a difficult time dealing with it. So there's a couple of resources there if you're not familiar with them. There's a lot of work being done in this field, thank goodness. And then when I teach to nurses groups, unfortunately, I have to put this up here because our suicide rates for nurses and doctors were high before, you know, twice the rates in the general population prior to COVID, and unfortunately have increased significantly during COVID. So just some other resources there for you. And then within our toolkit, there's a lot of resources. So a lot of the things I mentioned today and references are all within the toolkit for and available for you. So let's talk about the scope of this problem. And as we go through this, this end, and we're talking about legislation, think about your own programs and where you are with defining workplace violence and, you know, the elements of the program and your organizational culture. So as I go through today, hopefully it's a little bit of a gap analysis for you as you think about the environment you're working in. Before I define workplace violence, so I just want to put all of this in context. Musculoskeletal disorders are the leading cause of injury and cost to workers in the US in healthcare. Even through COVID, and I'll talk about what's happened to our healthcare workers in 2020 alone later on. But we can't forget that MSDs are the leading cause of injuries across the continuum to healthcare workers in the US, and the number one being manual patient handling. Slips, trips, and falls are number two, and violence is number three. And the three of those hazards together account for 79 to 80% of all the injuries to healthcare workers and of all the workers' comp costs. So if you can tackle those three topics in your facility, you go a long way to creating a better culture of safety for our workers and for our patients. You can't ignore some of the other hazards, such as bloodborne pathogen, needle stick, you know, and psychological stresses, which are related to violence as well. But I just wanted to put some context around this because I see us all in the US shifting to this topic of violence prevention, yet we haven't addressed musculoskeletal disorders, and they are disabling and they are life altering. And now we see some very early evidence that they may lead to earlier death rates. So this is very early evidence in the mining community, but those with low back pain and chronic MSDs are dying sooner. So, you know, I just want to kind of give you some food for thought there. So let's define violence. And why is this so important? This is the foundation of your program. However you define violence is going to inform your employees, what are they going to report? And we know that underreporting of workplace violence in healthcare can be up to 90%. And we'll talk a little bit about why that occurs later on. So however you define violence for your facility is going to drive your reporting and engagement of employees to some extent. So this is the OSHA definition, and I like this one because it's broad. The Joint Commission definition is very similar. I was a subject matter expert for the development of the Joint Commission standard for violence prevention, and they really took a very broad programmatic approach that followed the OSHA approach, and I was glad to see that it wasn't too prescriptive. Now, some of you will have state laws. I'm more familiar with the West Coast and the Nevada, California, Oregon, and Washington. And those state laws define the threat or act of violence as something that can cause physical and psychological harm, which can be a little bit of a gray area to define to employees. But whatever you look at as a definition, it's got to be broad. And, you know, acts of violence can be perpetrated by anyone, not just our patients, as we know. So you need to make sure that's well defined. But here's the kicker. I like to see the definition of violence include intentional and non-intentional acts of violence. Because as a nurse, If my patient hits me and they have dementia, or I work with brain injured children, and sometimes it's very hard to know when you're ambulating them what their triggers for violence are. And we've had a lot of violence associated with ambulating brain injured patients, particularly our teenagers. They don't mean to hit you or kick you. So is that an act of violence? And I can tell you the nurses I work with say, no, they don't mean it. We're not going to report it. I will if I'm injured, but if I'm not injured, I won't report it. So it's very important that you define intentional and non-intentional violence in your definition. You're probably all familiar, I'm going to put all of these on the screen, you're probably all familiar with the major 4 categories of violence. I think worldwide, I think the World Health Organization use this as well. It's pretty well accepted globally. Our type 1 level of violence is someone with criminal intent that has no relationship to the employer or that facility. Type 2, which is the more majority of the violence we deal with in healthcare, where the perpetrator is a customer or client, i.e. the patient, family member or visitor. Type 3 is where we have that co-worker bullying. It can be lateral, it can be between co-worker and manager, we call this lateral violence bullying. And actually there's a relationship between type 2 and type 3. So we cannot ignore type 3, and your program should address all of these levels of violence. And that's what Joint Commission requires as well. And then type 4 is our personal relationship. So this is usually where you see domestic violence occur in the workplace. This is on the increase in healthcare, especially as related to active shooter or gun violence or threat with another type of weapon. Those are our 4 levels of violence. And then of course, active shooter can be tied to any of these types. When we're looking at that. I'm just going to, I'll leave it at that. I'm just looking at my notes here. So let's get into some statistics. This is from the National Safety Council from 2020. And this looks at intentional injury by another person. So this is intentional violence. This is private industry, so not our state-run hospitals. And these are illnesses and injuries involving days away from work per 10,000 workers. So it's a rate. And you can see the ranking here for the top 5. Interestingly enough, educational services was really growing. The rate was increasing significantly until 2020. And of course, then we went to home learning, distance learning because of COVID. Whereas the service industry, the rate of violence increased 50% in 2020. And we can discuss why that is. We don't have time today, but we've all seen it in the news. Healthcare and social assistance has stayed fairly much the same. We've seen a pretty dramatic increase in the last 5 years, and it's been fairly level according to these rates since then. Most of the injuries are, or the nature of the injuries are hitting, biting, kicking, and scratching. And a majority of these assaults involve females. And if you look at the population in healthcare and educational services, that is probably why. Although with the Me Too movement, I think a lot more women are speaking up in the workplace about violence, whether it's type 2 or type 3. So just to give you some idea, you can download this data and other work-related injury data from the National Safety Council. And this shows you the trending here, where we look at healthcare social assistance, the increase in numbers of violence versus all other industries, and there has been a steady increase. And the numbers in 2020, we had over 15,000 reported cases of violence with days away from work in healthcare, whereas it was 4,800 in general industry. And of course, we did have a shutdown. We were locked down for summer 2020. So when we're looking at 2020, 2021 data, and we won't know that for another year, we have to really put it in context of the pandemic and what was going on. So we're going to have a couple of years of kind of erroneous data to some extent. If we look at the, a little bit more about data here, and I'm giving you this information because when you're educating employees and your C-suite and leadership and managers, you kind of need to have some background to put this in context. So when we look at the rates of assault in healthcare, it's nearly 5 times greater than any other industry, especially the rates of those incidents that involve time away from work. And I'm sure most of you knew that. We have higher rates of violence in hospitals, and usually that occurs in the emergency room and behavioral health, no surprise there. But we see violence in every area of patient care. And we really don't know a lot about ICU and med-surg. There's a lot we don't know about violence in healthcare in the US, about rates and the scope. And there's a lot we don't know about evidence-based programs because we haven't had that time to study them, unlike safe patient handling or bloodborne pathogen programs or slips, trips, and falls, for example. We know there are also high rates in long-term care. And in fact, rates of violence are about double that of in long-term care, are double that of those in hospitals. When we'll, for home care, I'll just throw out a few stats we really don't know, but about 60% of home care employees say they've been exposed to violence. That was a couple of studies. We're not sure about EMS workers. There was a global study that said 98% have been exposed to violence, mostly due to drug and alcohol intoxication, and it was mostly from patients, no surprise there. And there was a study done in 2017-18 in California that showed that they'd seen about a 40% cases of violence in outpatient clinics. But again, this is the data is all over the place. So there's a lot we need to learn yet. We have some professionals that are more at risk. No surprise, psychiatric aides have 10 times more exposure than CNAs, for example, who have 5 times more exposure than nurses. But it depends again on the environment that you work, because it's going to vary on the environment and your patient service line. Just to give you a couple of other stats, the ANA did a Healthy Nurse, Healthy Nation survey in 2018. 29% of RNs reported being exposed to verbal violence in the prior year, and 10% were assaulted in the prior year. And then there was a very large study done of 3,500 doctors, emergency room doctors, in 2018. 47% said they'd experienced, had been assaulted at work. And 80 to 96% male and female doctors had experienced unwanted advances of a sexual nature during their work from patients and family members. And while I'm thinking about this, when we did our large survey of 1,400 staff in Oregon at 4 hospitals, we were surprised at the number of staff that reported sexual assault or unwanted advances from patients and family members. And I think this is an area of violence prevention we don't really recognize, and we don't know how big it is. So don't forget that you need to address that as well when you're looking at your violence prevention programs. And a staff survey is one way to get to the root of what's going on. And in the toolkit, there's examples of surveys and how to report out that data for you. We have the perpetrator is mostly the patient, no surprise there. And I've said we have a lack of data about what's really going on in healthcare. And I think the last 2 years are going to make this a little bit more erroneous for us. And then we have a high level of underreporting that I've mentioned. We'll get back to that a little bit later. What I thought I'd do is try to look at violence that has occurred in 2020 during the pandemic. This is the data we really have. We're always 2 years behind with our data, typically worker safety data. But just to give you some idea of what's been published so far, one study from the Association for Healthcare and Hospital Security Staff and Safety, they said the assault rate in hospitals increased from 23%. And they look at their assault rates per 100 beds. So from 10.9 to 14.2 in 2020. This wasn't a very large study, and there is a lot of caveats to this, but just to give us a kind of ballpark. And then the Bureau of Labor Statistics reported an increase. I actually took their 2019-2020 data for injuries involving days away from work. The rate is per 10,000 full-time workers. And I noticed an increase in violence-related injuries, intentional and non-intentional related injuries, of 35% to RNs and 18% increase to CNAs. So that's just from my analysis from the BLS data, and you can download that for yourself. And then there was a fairly large study done in 2020 at the beginning of the pandemic, and there was a significant increase in physical and verbal abuse when nurses were caring for patients with COVID, particularly in the ICU, and that can be attributed to the oxygen deprivation of those patients. So of course that involved in decreasing brain function, cognitive function, and they associated that with a lot of the increased levels of violence. Now, outside of the ICU, a lot of this was attributed to differences in political opinion and so on, all the things we've seen in the media, unfortunately. Active shooter, I'm just going to throw this up for you. You know, we have some pretty good data. I'd say it could be better. I don't want to focus on active shooter today. I know a lot of hospitals do. We have to be prepared. But this is a subset of a whole workplace violence prevention program. So just to give you some data, I think what we've seen in Portland, Oregon is not so much active shooter in the hospital, but in the area surrounding the hospital. We've seen significant gun violence and gang activity in Portland since 2020. It's the worst it's ever been, I'll be honest. We've been on the news. It's the same in Seattle and LA to a certain extent. And we've had several lockdowns because there's been an active shooter in the vicinity of the hospital. So we have to be prepared for that as well. You know, about 20% of the victims are actually staff when an active shooter is in the hospital, and about 23 to 25% of the shooters get their gun from security who are armed within the hospital. So just something to think about there. But I didn't want to spend any time on this. I will say that homicide related to domestic violence, as I mentioned earlier, is on the increase and is accounting for a lot of these episodes. And some of you that are on the call that are in security might have some more updated information than I do. It's not always that easy to find. Just to add here, I don't want to ignore type 3 or bullying. Here's just some data for you. Unfortunately, in healthcare, we tolerate bullying. When I work with other industries, we don't tolerate it in the same way. And in fact, you might be involved in a lawsuit or terminated if you're a bully at work with certain behaviors. But this has been our history, and it's not just in the US. I saw this when I was a student nurse many years ago in the UK. In fact, we used to have hazing of student nurses, and I won't say what we did, but it was pretty appalling. We eat our young. That's the awful saying. There's even a book by Kathy Bartholomew that explores this topic, but nurses eat their young. It's an awful saying. And if we don't address this, you're not going to get a good handle on your type 2 violence either. And I'll get back into that in a little bit. And if we want to keep our staff on the job, we have to address bullying. So what's the true cost of workplace violence to employers and patients? And then I'll talk about the cost to employees in a second. I will just preface this by OSHA has recently said that we saw a 40% increase in injuries and illnesses overall to healthcare workers in 2020. Now, a lot of that was exposure to to viruses, the COVID virus, SARS-2 virus, but it was also an increase in violence, increase in musculoskeletal disorders, increase in slips, trips, and falls for many reasons. And as we get through this iceberg, which I'm sure you're familiar with, I want you to think about what you measure at your organization and what can you measure that's going to be under the iceberg. Because if we have underreporting with violence, we're not going to have a lot of workers' comp data to measure and manage our program. And that's what we found in Oregon. There was very little valuable data on the OSHA 300 logs. We looked at code gray logs that could tell us a little bit more about incidents of violence. But when it came to injuries and workers' comp, because of the underreporting, we didn't have a lot to go with. But we'll start with that. So we've got our time away from work, our medical care costs, that's our direct costs. You can get these from your work comp carrier. And then you might want to look at your indirect costs. And we do this at a local hospital I work with. They actually calculate that when nurses are off work for an injury or on modified duty, or maybe CNAs or others, we calculate what it costs to replace that staff temporarily. And those costs are double the direct costs. So you might be able to do that working with payroll and HR and your risk management to get an idea of what does that temporary replacement cost look like. Under the iceberg, some of you might be familiar with this. When we look at the impact of violence to the organization and our patients, we know that it impacts turnover and sick leave. So just some statistics for you. 1 or 2 studies have indicated that those staff who take sick leave that have been exposed to violence take 60.4 hours a year, average 60.4 hours a year more of sick leave versus someone who is injured and wasn't exposed to violence. We know that those staff that are exposed to violence are more likely to leave the job. And this pertains to type 2 and type 3. This is not just patient-related violence. And we also know that 1 in 5 RNs intend to leave the profession in the first year out of graduate school, 1 in 3 by the end of year 2, and this is prior to COVID. And I'm sure most of you have seen the data that 25 to 30% of healthcare workers in the US want to leave healthcare because of the impact of the pandemic and what they've been through, and burnout and stress and injury, mental and physical injury. And that's not including all of the nurses who were meant to retire this year, next year. So this is a global issue, our issue of staffing, and now using temporary staff who don't know our environment and our equipment. As an ergonomist human factors engineer, I'm extremely concerned with the outcome for patients when we have a lot of staff who are not trained, and we don't have time, budget, resources to train them well, and who are making it work as they go in their day-to-day practice. And I talk to my colleagues about this all over the country. We're all seeing it, and we know this is going to have a detrimental impact on our culture and patient outcomes. One of the statistics, when we look at being short-staffed, we know that when nursing workload increases, the likelihood of patients dying within 30 days increases by 70%. And again, there's a lot of data looking at workload of nurses and patient outcomes prior to COVID. I'm waiting to see what happens as part of the pandemic. And if we're looking to replace nurses, we know that cost is about 125% increase in cost versus their salary. So anywhere to about $125,000 to replace a nurse. So we see this turnover with not just our nurses. It's a huge cost to the organizations, and it has a direct impact on patient care and outcomes. And then, on the other side of this is, if we don't address violence, we have increase in insurance costs, property damage, litigation. There is a cost because we need to look at security needs, our equipment, our personnel, our facility design. And then we have the non-compliance with Joint Commission standard OSHA regulation at the state level, or maybe the general duty clause. When we overlay this with the impact of musculoskeletal disorders, particularly from manual patient handling, I use the same iceberg when I teach about the impact of manual patient handling on employers, patients, and staff. The cost is huge. How many of your staff are working in pain and taking opioids because they're manually lifting patients and they haven't reported this? And then we overlay the stress of the pandemic and all that we've seen in the literature and what we're seeing in our practice. We have a recipe for disaster. And I'm not sure how we're going to address this going forward in a time where we have huge budget shortfalls. So I guess my message is, if you're going to address violence prevention, can you please look at it in context of patient handling, slips, trips, and falls, and psychological trauma? That it has to be a systems approach to take care of your employees, and then you're going to be able to improve those patient outcomes. And we'll talk a little bit about that later. Just to talk about this quickly, we know that violence costs employees dearly, including death. If it's a patient who has committed homicide and murdered an employee, physical injury, disability, psychological stress, and PTSD. Now, interestingly, we see more PTSD with type 3 violence, which is our bullying. And what nurses will tell you is, the physical injury that the patient caused is awful, and there's trauma associated with that. But the patient didn't mean to hit me. They didn't mean to strangle me. They're mentally ill, or they're intoxicated. But when I deal with stress and violence from a coworker, I don't expect that. That's far more shocking, and we have more of a psychological impact. So I think this is quite interesting. And again, both of these are related. And here's some of the outcomes with bullying, including decrease in cognitive abilities that lead to impaired clinical judgment and medical error. So there are several studies that have looked at this in the nursing population. So if you're not aware of that, it's something to think about. I'm not going to read these, but this is a summary of what we know about the cost of violence-related injuries. Now, there's not a lot of great data out there, but I've put a link into the Hospital Association data and the report that they've published that might be helpful. And there's just some other data there for you. It's hugely costly. But again, what can you measure in your facility above and underneath the iceberg that gives you an idea of the true costs for you? And then how are you going to measure use that to measure your program? So the question is, how much of reimbursement do I need to offset the cost of these injuries due to violence? And just for fun, if you've never seen this, you can download this from federal OSHA. This comes from a research study by Speroni, who looked at what the cost of workplace violence related injuries are. He came up with about $94,000 on average per injury. This is a very small study, but I'm just going to use this. So if you looked at your workers' comp claims just for violence, you can do this for any safety issue like patient handling, for a period of time. This is direct costs only. You look at your profit margin, and I used to put a profit margin of 4 there, but we're lucky these days if we can get 2, especially if you're a rural hospital. And if I divide that amount out by my 2%, this comes up with over $4 million that I need to make in additional reimbursement to offset the cost of these claims. Now, when I do this with patient handling related claims, it comes into the 10, 20, $30 million amount. So just something to think about to really get you looking at what's this truly costing us. And it's costing you hugely. It might not be obvious, but it can be very substantial. So very briefly, this is really an FYI because I want to get into culture and programs, but this is our current summary of legislation and standards for you. We have the OSHA general duty clause. So if you're not you don't have a state OSHA and you don't have a specific violence prevention law for your state, then this is going to come under the general duty clause. Whereas an employer, you have to provide a safe and healthy workplace that's free from recognized harm. And the employees have a duty to report and follow the safety rules. And then we have this HR 1195, which passed the House in April last year in Congress. It is now in the Senate in the Labor Education Committee, I believe. There is a huge push by the unions and federal OSHA to move this bill forward. It would be a very programmatic approach to a federal violence prevention bill. It is modeled off the California law, and the one piece that I don't like about it is the definition of violence is a bit too nebulous for me, but it is programmatic. It's not too prescriptive. So kind of watch this space and see if this goes forward, but you certainly can download it and look at the law, and it's going to parallel what I'm talking about today. There are many laws, there are many states with workplace violence prevention program laws, and there are many states with assault protection laws. And unfortunately in Oregon, ours failed about 2 weeks ago for about the 10th time we've introduced it. It was supported by the Hospital Association and the unions. However, there was a body of our legislature who thought that if we said a nurse could file assault charges against a patient who committed violence, it would stigmatize those with mental health issues. So it's a very hot topic right now, and there are pros and cons on both sides. However, we protect our EMS workers in Oregon and our highway workers against assault. But our healthcare workers are not protected in hospitals. They are in Washington. It's very variable. One of the problems with all the state laws, and it's the same with patient handling, none of them are really measured. They're all so variable that we don't have any consistent standard or for benchmarking. That always worries me when we see state by state laws. So a federal law, whether you would like one or not, having one rule that we can all measure and benchmark against and be on the same page might not be a bad idea, but you will see what happens. Don't forget you're complying with Joint Commission and DNV if you're under those accreditation agencies, and there are other for long-term care. And then don't forget your security laws at a local and state level. So we have a lot of laws when you're hiring private security in Oregon. We have to provide training. We have to have an emergency manager on staff to supervise those contract or security employees. So, every state is very variable there. And then you'll probably, for those of you that are Joint Commission accredited, you should be familiar with their changes to some of their environment of care, human resource and leadership chapters. I'm not going to go through these in detail with you. You can read these. These are the primary changes that I've summarized. We're really looking at having a committee that really develops a program plan, looks at safety and security risks on a periodic basis, addresses them, documents that, follows up and investigates incidents involving patients, staff, and others related to violence, and that you provide workplace violence prevention training, and the content is actually outlined for you. I think, you know, if you've got a program approach, as we're going through today, you're going to meet the Joint Commission standards. I would just make sure that it's documented clearly for OSHA purposes and the Joint Commission. So why does violence occur? I'm watching my time here, and I'm not going to read all of these. But in a nutshell, we have to think about this in what can we control, what violence can we prevent in our healthcare facilities, and what can we control? Because patients will walk into our emergency rooms and they're already escalated. And we have a duty to care, we can't turn them away. So how do we control the outcomes and not have anyone injured, including the patient? Whereas there are some factors that we can, through design and our program designs and facility design, can mitigate violence and prevent it. So first of all, we look at clinical risk factors. And of course, these are going to vary by location and your patient service line. But, you know, we've got a lot of different clinical risk factors that contribute to violence. And in the toolkit, the first tool 1A has looked at all the research and summarizes those risk factors for you. So take a look at that for more information. And then we get into the environmental and the organizational risk factors. And these are risk factors that you can control as an employer. Through program design, facilities building design. So we know that high noise, crowded waiting areas can lead to more aggression and violence, poorly lit areas from a security perspective, increased wait time, poor communication, lack of staffing, not the right staffing, ineffective training, working alone, working with cash, working on night shift. You know, all of these things are well documented in the literature. OSHA has documented them. And again, we have them in the toolkit for you. So when you're designing your program, you can address a lot of this. And then we have the social and economic risk factors that, you know, are in our communities right now, have definitely got worse in the last few years, are a global issue that spill over into our hospitals. So can you work with your community partners, such as behavioral health, the local sheriff, law enforcement, to really come to some understanding and try to prevent and control and mitigate where we can. You know, when we did our project, we had a local critical access hospital where the local police on a Saturday night would pick up anyone that was intoxicated on the city streets and dump them at the ED. And I use the word dump because that's what it was. It was at the front door. And it would overwhelm our emergency department. So in our project, we worked with the local police and the sheriff's office, and those two departments didn't work closely together. So we worked on that too, and really developed that rapport with them and EMS about how do we manage these patients on a Saturday night and at other times. So that's just an example of how you might work with your community. And then, of course, we discharge our mentally ill patients, our behavioral health patients, into the community, and there's no resources for them. In our critical access areas, our rural areas, we have closed so many behavioral health resources. And they're often, these patients are sitting in our ED while we're waiting for a bed at a hospital or a resource 300 miles away in Portland. So there's a lot of work nationally and at state levels to address this. It's complicated, it's not easy, it's also very expensive, but we have to address this better. And then these are just some data from Joint Commission about a study they did a few years ago that looked at why violence occurred, and they saw these factors. Communication, for me, is a big one between the patient staff and the staff and the staff. And you can read these, but just to give you some idea for your programs. For bullying and lateral violence, the reason I've included this is because it really looks at why bullying occurs. And this is part of your culture. Cultures that allow bullying to occur are not going to be successful in preventing patient violence. They might start off with a program that's effective for a while, but because this is endemic or it's incorporated into the culture, if you haven't addressed this, you know, that long-term sustainable program for violence prevention is not going to be successful. And that's what the literature tells us, and that's what I've seen in my practice over many years. In some of the organizational factors that lead to bullying, you can see here, leadership style is key. It's been well researched. So where we have transformational leadership, the high reliability, just culture organizations, we see better patient safety programs, better patient outcomes. We don't see the bullying, it's not tolerated, and we see less patient violence. So we don't have time to get into all of these, but just something to think about, because when you assess your environment, when you're designing your workplace violence program, the first thing you do is a culture assessment to know what's going to work. What am I able to do? What kind of culture do I have here? And one of the challenges for us in healthcare is our culture is changing all the time because we see so much turnover at the direct care staff level and C-suite level. So here's the relationship between type 2, type 3 violence and what we know right now. This is early stage research where we have a poor organizational climate of safety. We see increase in type 2, type 3 violence. We see where there's a lack of supervisory support after an incidence of violence, and particularly where there's bullying or any safety incident, we see more type 2 violence. So where we see at that unit department level, poor support from supervisors, we see increased issues related to safety, staff safety and patient safety. And this goes beyond just violence. Interestingly, there's a lot of research that's done around supervisory support when you're having family-related issues, and that spills into work. So when we're looking at total worker health here, we're not just really addressing the safety issues on the job, we're really looking at that holistic picture when we're thinking about taking care of our workers and supporting them through the tough times off the job and on the job. Now, again, that's a big topic, but I just want you to think of that systems viewpoint, because we now know that's just as important. Some of our barriers to implementing violence prevention programs, and again, I just said, this is what you're going to look at when you're looking at your program or enhancing or starting a program, and you start with that culture review. This is the same for every safety program, whether it's patient or worker safety. What's the leadership style? Is it inclusive? Is it transparent? Do we engage our staff? Do we have that high reliability organization? Do we just focus on patient safety versus worker safety? That's what we do in healthcare. That really has to stop. If you want to retain your workers going forward, make your profit margins, retain your patient base, have a good patient experience. We have got to engage our workers. And I'm not just saying that from 30 years of practice. We have the evidence to support that now, especially in the light of COVID. Competing demands, that's always a challenge: regulatory, resource, budget, lack of systems approaches to services. You know, we have physical therapy versus nursing, maybe our medical providers. We have department versus department. You know what I'm talking about when I say silos, and we have to break those down and get to that systems approach. Do we blame the worker when something goes wrong, or do we look at the root cause analysis, which is always a systems failure, unless we've got horseplay on the job and, you know, it's a deliberate attempt by a worker to do something harmful, and that's extremely rare in healthcare. Do we underestimate the true cost of injuries in relationship to patient safety? That gets back to the iceberg that I just presented. Most C-suite I work with, when I look at their data, they had no idea what it's truly costing them in work comp dollars, time away from work, turnover, and impact to patient safety. And then, you know, what's the relationship to other programs? I've mentioned already slips, trips, falls, patient handling, and so on. And then this staff turnover issue. I think for healthcare particularly, I was actually presenting to a group from industry last night, and I said they wanted to know about materials handling in healthcare. And I said, you have to understand our culture and the challenge of constant turnover in staff and training, and the cost to do that and resources, more challenging than ever. So if you can develop culture-based programs that are sustainable, we can address that. But let's get into a few more barriers here. I'm not going to read all of these. These are specific to workplace violence. We learned this in Oregon. It's in the literature. We have a lack of expertise in workplace violence. We have a lack of expertise internally for training. We often like to contract with training groups in violence, and that's great, but there are some limitations I'll get into in a minute. But we often don't have effective policy and procedure. Do we know what effective worker training is? Do we have effective reporting systems? And then these are some other barriers we've seen in the literature. I can let you read these later. But, you know, one of the things that we deal with is if we report violence and assault on a nurse or a doctor to the law enforcement folks, do they take it seriously? And we find in Oregon historically that there's a lack of information and education to our DA, to law enforcement about how to deal with these cases. So they're often dismissed, and it's not intentional. It's, I think, the lack of that education and bigger picture here, and being short-staffed and overwhelmed. So our barriers for reporting, interestingly enough, this is well documented in the literature. This is what you want to find out in your facility. When we surveyed 1,400 staff, not just direct care staff, this was support staff, admissions, billing, and so on, in our 4 hospitals, they came up with the same 3 barriers as we saw in the literature. If I'm not injured, I'm not reporting. If the patient didn't mean to hit me, bite me, scratch me, verbally abuse me, I'm not reporting because they don't mean it. Did someone else report this? They must have done. They must have witnessed this. I don't have time. There's no policy. It's not clear. The reporting process isn't easy. It takes longer than 10 minutes. I have to go through 10 pages on the website to find the incident report. Fear of retaliation is huge by coworkers, patients, and family. In our small communities, everyone knows everyone else. And we have actually witnessed this in Eastern Oregon in an outpatient setting where we had to send security because the employee who'd reported violence was so fearful that the family would come after her. So you have to consider that, especially in our smaller rural communities. Poor management response, poor coworker response. There's no follow-up. I report violence, nothing happens. The stress is awful. But you know, if you're not going to circle back to your employees and communicate with them and support them, they're not going to report. And they're more likely to think about going somewhere else to work, especially now. Stigmatization by coworkers. This is part of the way we do the work. And I do think health workers come to work, healthcare workers come to work and expect to be injured on the job. This is not just related to violence. And then the response by law enforcement. So definitely things to think about there for your programs. Now, before we get into the program elements here, and I know I'm watching time, I do want to just show you some slides quickly. You can read them and download this information. If you're not familiar with it, I highly recommend it. About 8 years ago, I became aware of this work from the Lucian Leape Institute, which is now within the Patient Safety Foundation and IHI. And what they said is, and they recognize this from my world of human factors, if we don't address workforce safety, we can't expect better patient safety or improved patient outcomes. And remember, we're not #1 in the world for patient safety. Unfortunately, I think we have one of the best healthcare systems in the world. Prior to COVID, I had the privilege of going around the world and working with many different systems. And I really think we do, but we're not #1 for patient safety. And one of the leading reasons is we don't take care of our workers. So the joy and meaning of work is this, you know, that we really include that. You can read these, but the last one here is that we really look after our workforce safety. And, you know, these are how to find joy and meaning in daily work. Your workers, and that's everyone from the C-suite to EVS to direct care staff, your contract workers as well, your traveling staff, are these 3 questions. And the last one is easy for us. Am I recognized and thanked for what I do? It's not always about benefits and salary. It's about saying thank you and communicating clearly and supporting our staff. And now more than ever, this is critical. So you can download these. This is a actions to advancing joy and meaning in workforce. You can download this from IHI. They have a lot of support tools. I highly recommend this, especially as you're developing, you know, how do we develop a support staff who are stressed out right now and maybe dealing with PTSD. And these are our dimensions for joy in work. You can see it's very much a systems approach. It parallels total worker health, which is a program that NIOSH has been promoting for many years now that takes a holistic systems approach to workforce safety. So again, you can download this if you're interested. What I did want to highlight is that IHI worked with 27 organizations, and in 2020 updated their plan for advancing patient safety in the US. And you can see these elements here in number 3 is workforce safety. And I'm so glad to see this within these 4 key elements. So, you know, we really have to work on this if we want to make progress with our patient outcomes. And here's some other links for you. And I really think COVID has a silver lining, if you can say that. We now are focusing on the physical and psychological health of our workforce, not just in the US, but worldwide. And we now value, if we want to keep and retain our workforce and attract them and recruit them, we have to take care of them. So just to finish up here, and I've given you these handouts. I've also provided some evidence for workplace violence programs at the end that you can look at. We won't have time to review. But what are our components of sustainable programs, we think? So we don't really know because we don't have long-term studies, but we're going to base this on the OSHA approach to safety and ergonomics programs and what we know from the literature. And this incorporates our toolkit and what I've learned over the years. So we have to have that program foundation, which is management leadership and employee participation. And I've already said a lot about management leadership style. It has to be visible and engaged. So management by walking about, if some of you have heard that, we used to do that in the industry in the 90s. Goes a long way. Employee participation means at all levels of the program, on the committees, soliciting ideas through surveys, informational focus groups, you know, but really getting them engaged every step of your safety program. Written policies are great. I don't usually write policy for my safety programs until I know what the program's going to look like. And be cautious if you say zero tolerance for violence. CMS and federal OSHA have published a kind of a white paper agreement because they see this from different sides of the coin. OSHA says zero tolerance. CMS says you have a duty to care. You can't turn patients away, even if they're violent. So in the toolkit, there's a link to that paper, but just be careful. Zero tolerance for bullying, absolutely. But for patient violence, we need to approach that cautiously. And then your program management, I always add this in, you've got to have some good project management for these programs. So you want a champion at that C-suite level who can really communicate about the program and go to bat for the team. You want a project program manager, coordinator, you need an interdisciplinary team, and you need a program plan. And all these are outlined in the toolkit for you. You then need to have a communications or social marketing plan. Most safety programs, I rarely see this, but this looks at all your stakeholders from patients to C-suite, everybody that's going to be touched or impacted by your violence prevention program. What do they need to know? When do they need to know it? Who's going to deliver that message? And what are your resources to do that? So in the toolkit, there's a whole template for you that's been made with free resources that you can adapt for your communications plan. And this will feed into your training plan as well. And then, you know, hazard identification. How am I going to identify what the scope of the issue is? And how am I going to measure my program? So as I said earlier, injury data is sparse when it's related to violence. So you might look at code gray data or code white, depending on what you call it, patient surveys, worker surveys, a gap analysis tool, and then frequent assessment of the physical work environment. And all of these tools are in the toolkit for you. So it's not just looking at the OSHA log. Then we have hazard abatement. So we have engineering controls. We don't have time to get into these, but this is change to the physical environment to reduce the risk of exposure to violence for patients and staff. So this would be your security, surveillance and lighting, noise barriers, metal detector systems, and so on. And then when we look at the evidence base for what we know is effective, remember that previous list, not all of that is evidence-based. This is just from anecdotal data and case studies, which right now are just as valuable in my view, because we don't have long-term studies. But what we do know is that closed circuit video surveillance is very effective in adequate lighting, visibility in treatment rooms, knowing where your coworker is if they're alone with a patient, right? We actually don't know if panic alarms are effective. I know a lot of you use panic alarms. We do in the hospitals I work with, but there's actually no data to support that they reduce the risk of violence or the outcomes. We need more data on that. And then securing furniture so it can't be used as a weapon. And there are some nice resources out there for furniture that's really, you know, looks like home furniture. It's nicely designed, but is designed that it can't be used as a weapon. Now I'm going to flash all of these up. We get into our work practice administrative controls. So these are policy and procedure related. The big ones here are really incident reporting, identifying patients at risk for violence. How do we respond? And then how do we follow up post-incident? And then how do we investigate the incident? That's the core of these programs, along with facility design. We have other things to look at. This is not all inclusive, and in the gap analysis, there's a comprehensive list there, but what's evidence-based? And this kind of narrows down to using a validated risk assessment tool to identify patients at risk for violence within the next 24 hours. And there are 1 or 2 tools out there that have been well studied in the behavioral health arena that have been adapted for the acute care, long-term care arena. So those are in the toolkit. And I highly recommend, if you're not doing this already, that you have some kind of assessment or check process throughout your facility that's well defined and then well communicated to identify the risk for violence with your patients and visitors if possible. And then how are you going to communicate it? We've seen a decrease in violence related to if we flag violence in patient records, but there's also some studies that say that doesn't help us. So there's context for this. And then again, all of this is in the toolkit in section 5. When it gets into interventions, there's a lot of links and examples of tools for you. Behavioral health rapid response teams definitely are valid. And I know I'm running out of time here, so I'll just flash these up for you. There's some good support for safe assessment rooms where it's a quiet area. We can assess and de-escalate patients as long as there's visibility to get help for our staff. And then education and training has to be evidence-based. So if you do hire a consulting group, make sure they've customized the training for your program and the state law. And make sure that it's valid, it's transferable to the real world. And again, in section 6 in the toolkit, there's a good explanation of how to do that. And then we have ongoing proactive hazard analysis and so on. So I know we're near the end of our time here, but just remember our hierarchy of controls. We like to isolate people from the hazard first when it comes to violence. And then a lot of violence prevention is related to policy and procedure change, which means we have to supervise for it. And that can take a lot of resources and time. And you notice down the bottom, of this triangle is training and PPE. So training alone will not be effective. In the toolkit, there is a summary of how to implement a program for you. It's using your plan, do, act, check approach. And then lastly, these are your outcomes and what we know about outcomes and research so far. So what's effective? And this is the best data I can pull because we need some large studies conducted, and they are being conducted, but there's some links for you here. And then finally, and I know this is a lot of information, just to summarize, have a plan, set measurable goals and evaluate them often. Start small, test your pilot interventions such as patient risk assessment tools. Don't reinvent the wheel. There's a lot of help out there. Involve all your stakeholders. Plan for sustainability and moving to a proactive program versus reactive and waiting for violence to happen. Engage everybody, market, communicate, and then treat patient and employee safety with equal emphasis. And thank you very much. And I apologize for running over on time there. And I know they're going to send the handout out to you. Thank you, Cassidy.
Thank you so much, Linda. And I know we're over by a couple of minutes, but it's really useful and important information. And we appreciate you being here with us today to share it. I did go ahead and we had a question about how to get a copy of the presentation or the slides. And I made a comment in the chat that we will be sending an email tomorrow from CORE that will include a link to our website, which has a recording of today's presentation as well as the slides. We will also include a link to our 60-second survey if you have a moment to complete that, to just let us know your thoughts, and then anything you might like to see us host a webinar on in the future. We would love to hear from you. That link is also in the chat. So once again, thank you for joining us today, and a huge thank you to you, Linda. We appreciate your time, and we look forward to seeing everyone next month. Thank you.
Thank you so much. Thank you for inviting me, Cassidy.
Absolutely.
Take care, everyone.
Bye-bye.
Bye.